Hello, our webinar will begin in about 30 seconds. Hello, welcome to the National Consortium of Telehealth Resource Centers, Telehealth Hack Series, Rehabilitation Services and Early Intervention. My name is Mei Kwong. I'm the Executive Director for the Center for Connected Health Policy and the National Telehealth Policy Resource Center. Next slide. Please know that any information that you provide in your registration form today will not be shared. Next slide. The National Consortium of Telehealth Resource Centers is made up of the 14 telehealth resource centers who are underneath the same program through HRSA. There are 12 regional resource centers that cover specific states and 2 national centers. CCHP is the one on policy, and there is one on technology based out of Alaska. All 14 telehealth resource centers work collaboratively together on joint projects such as this Telehealth Hack Series. Next slide. For those of you who attended the Asper Telehealth Hack Series back in 2020, the summer of 2020, that was a limited series that ran for 10 weeks. It was transitioned over to the Telehealth Resource Centers, and we've been running this program since October of 2020. This is the final month of the Hack Series. We will be ending it after the webinar that will take place 2 weeks from now. Next slide. A couple of tips and notes for today's webinar. Please note that your phone or computer microphone has been muted. If you have a question for our panelists, please use the Q&A function at the bottom. For technical assistance in Zoom, please use the chat function. Attendees are able to adjust their video using Zoom's sliding features. And also note today that for the webinar, the closed captioning is available, and you'll see a button on your toolbar down below. Additionally, the webinar is being recorded, and the recording of the webinar and the PowerPoints will be posted within about 48 hours on the Consortium's YouTube channel and on our website. Next slide. CE credits are being offered for today's webinar. This is a disclosure policy from the University of Arkansas. Next slide. More information about the staff that participated on preparing this. Next slide. Additional information. Next slide. To receive CE credits, you must create a profile and learn on demand. If you have already created a profile because you attended previous hacks, you do not need to do that again. But if this is the first time that you are seeking CE credits, you will need to create a profile first in order to receive those CE credits. Next slide. All you do after you've created your account is to log in, look for this particular webinar series, and you'll be able to just follow the instructions there, and the certificate should be emailed to you after you've completed all of the instructions and questions that are in the system. Next slide. Please note there is a very hard and fast specific deadline. In order to receive your CE credits, you must complete the evaluation form by March 24th of 2021. Next slide. Again, another reminder that you must complete the evaluation form by March 24th to receive CE credits for this particular webinar. Next slide. I will now hand it over to Nicki Perisho, who will be your moderator for today. So Nicki, take it away.
Thanks, May. So the NRTRC is excited to introduce our panel for today. We have Benjamin Boyle. Ben Boyle is a physical therapist. He has over 15 years of experience in multiple settings. He currently serves as the Chief Clinical Affairs Officer for over 40 private practice physical and occupational therapy clinics in the state of Washington. His focus is on training in clinical development, regulatory affairs, and payment policy. Next up, we have Anthony Yengo. Anthony is also a physical therapist. He is the owner of Quest Physical Therapy, which is located just outside of Seattle, Washington. He is a certified manual therapist. He specializes in orthopedic physical therapy, and he started incorporating telehealth into his practice in March of 2020. And last but not least, we have Kaitlyn Andreason. Kaitlyn received her Master's of Science degree in Speech Language Pathology from the University of Utah in 2013. Following graduation, she spent 5 years in Arizona working as a contract speech language pathologist in school districts in Chandler and Mesa. In 2018, she was offered a job with Primary Children's Hospital and moved back to Utah to work in an outpatient rehab setting. Kaitlyn enjoys working with the pediatric population. When COVID-19 hit in 2020, she began researching teletherapy and then created a telehealth training for speech language pathologists in the outpatient setting at Primary Children's. Although teletherapy has its own unique challenges, Kaitlyn has enjoyed learning new ways to work with her patients. So without further ado, I'm going to hand it over to Ben to start us off.
Hello, everybody. Again, I want to thank the NCTRC for giving me the opportunity, giving us the opportunity to kind of share some of our experiences with telehealth. And, you know, as a representative and overseeing over 40 clinics, I would say that COVID-19 and the pandemic really has brought out a lot of new opportunities, some benefits from telehealth, and it really had quite an effect on our practice. I'll be being completely honest and up to date for, you know, even though Washington State's a state that have PTs and OTs had the ability to practice telehealth from a statutory perspective, it really was not on our radar kind of up until March of 2020. And then where we were suddenly faced with, you know, over 75% drop in our visits. We had patients you know, right post-op whose plan of cares were interrupted, and we really, as an organization, had to figure out what we were going to do. And thankfully for us and a lot of the practices in Washington State, we were able to kind of pivot rapidly to the telehealth option and provide telehealth services to our patients and continue to serve them throughout the pandemic. Next slide. So if we're starting off with just kind of what we had to figure out that first and second week in March was what exactly is telehealth and what does that mean from a statutory perspective? What's that mean from an operational or practice perspective? So for us, using telehealth is really about using a HIPAA compliant platform, providing an interactive service using real audio and visual communication. And we're really trying to deliver our healthcare services at an alternate site than where we're actually located. Next slide. So there's several different types of kind of modalities or mediums that fall under the telehealth umbrella. A lot of the time, and for us in Washington, it was really guided by kind of our statutory requirements for PTs and OTs on which kind of format that we could utilize for telehealth. So we have the live video, which is probably your most typical or most traditional form of telehealth, where you're using audio visual. It's in real time. You and the patient are kind of synchronous, meaning you're interacting together. And it's really kind of the gold standard accepts as substitute for in-person encounters. There's also some options to use what's called store and forward technology. This is asynchronous and really often it's used to kind of transmit health information over secure email or secure platforms. Oftentimes, in a lot of areas, this is used to communicate among specialists, right? Communicating clinical exam findings, diagnostic imaging findings, you know, and it's usually a specialty communication medium. And kind of one of the areas that's really emerging, and it's exciting for a lot of different reasons, but is the remote patient monitoring, right? This allows us to use digital technology to collect that health data from patients in a remote location, but in real time. So that's a pretty interesting medium that is definitely emerging kind of in our area. So like I said earlier, a lot of times it's the state law or the statutory requirements that guide how, when, and if you can use telehealth. So for PT and OT in Washington state law requires us to use at minimum audio and video equipment in real-time interactive communication between the therapist and the patient. Well, however, you know, and as we'll see a little bit from our survey, sometimes the technology and internet bandwidth issues led to a lot of problems in some of our rural areas, which allowed us to created an opportunity for us to advance in Washington what's called House Bill 1196, which would create reimbursement parity for audio only consultations in Washington state as well. So there's a lot of opportunities. I think that COVID-19 pandemic brought out a lot of opportunities, a lot of benefits, and a lot of barriers to telehealth, and it's a good opportunity to capitalize on those things legislatively. Go ahead, next slide. So this kind of as the pandemic continued on, APTA Washington and some of our primary payers in our state decided to do a large-scale survey about telehealth and PT, at least in our state, and kind of get an idea of what some of the demographics were, what a lot of the benefits are, and some of the barriers. Next slide. So we found that in kind of our state, the primary people who pivoted to telehealth, or the primary practice groups that pivoted to telehealth during the COVID-19 pandemic was private practice. And on a state level, that is really true in the fact that it was really what kept a lot of our private practices open and survived and allowed them to continue to serve patients. And then you can see kind of a smattering of other health areas that didn't necessarily still utilize it, but maybe not quite at the level that the private practices did. Next slide. When we ask people why or why not they're using telehealth, the good news is they all seem to be aware that the Practice Act allow for it, but there certainly were some questions if the patients would desire it or they would uptake it. There's some uncertainty around payment. There's some uncertainty about what level of care that you could provide over telehealth, and I'm excited to have the next presenters really kind of highlight what kind of quality care you can really provide over telehealth. So go ahead and next slide. So similar to our experience, even in Washington, where there was long-standing ability to provide telehealth, a lot of our practice groups and providers were not. 85% of our respondents did not provide telehealth prior to the pandemic. Next slide. But I think for the benefit of kind of practices and the benefit of our patients, telehealth looks like it's going to stay around, right? And with our collective experience with telehealth during the pandemic, kind of the benefits, the lessons that we've learned, almost 60% of our respondents indicate that they will continue to keep telehealth as part of their service lines going forward into the future. Next slide. And a lot of the things that we found most beneficial, and a lot of providers found most beneficial, really was the convenience factor of it, the ability to navigate around busy schedules, be able to work with the families as a whole, as well as really promote access in rural or underserved areas. Next slide. Obviously, a lot of the barriers, especially when you try to roll this out quickly, most of the barriers came around technology issues, right? Whether it be platform, internet connectivity, not having the right space or the right platform to do it. And I think that's really driven a lot of change, both on the provider side, the patient side, as well as kind of in the legislative arena, where there's, at least in Washington, there's several bills going forward looking to address bandwidth and internet access for all constituents in Washington. Next slide. So there's a lot of the big, as we said, a lot of the most positive aspects were really surrounded around being able to provide access in rural communities. Another really big one that came out, a lot of our pediatric therapists, which is very much a super subspecialized practice. When all the children went out of school who would normally receive services in school, they would definitely have their care plans interrupted. And I know that telehealth for a lot of those pediatric specialized therapists in the school system were able to pivot to telehealth and continue to provide those care plans for those students that were learning remotely during the pandemic. Go ahead and go next slide. Next slide. So when we kind of decided we need to rapidly pivot to providing telehealth across our organization, which is geographically diverse, we really kind of had to figure out kind of what were the steps that we needed to do to initiate that. So for us, we needed to figure out, are there any required training activities in our state? And so we do in our state as of January 1st, 2021, we do need to complete a mandatory training for all non-physician providers. This is offered by the Washington State Telehealth Collaborative, and all providers needed to have a record of them completing that training, as well as keep that certificate of completion on hand. We needed to figure out what platform we were going to use. There's a number of available platforms out there. All of them have benefits and minuses. I know one of the things that we decided as an organization, we were going to try to continue to use a HIPAA compliant platform. I know that a lot of situations that requirement was waived, but we decided if we're going to implement this as an organization, that we really want to try to use a HIPAA compliant platform. So a lot of the HIPAA compliant, one of the easiest ways to kind of know if it's a HIPAA compliant platform is if the need or the ability to complete a business associated agreement. So we used a platform that had that opportunity, and each provider kept that on file. The other thing that we came in is, were there any differences in consent? Were there anything that we needed to add to our informed consent process that would cover us for telehealth services? Really, it's still pretty much a standard informed consent process. What are the risks? What are the benefits of the procedure? But we did add some language or some discussion around what happens if the connection is dropped. Is the information being stored? The level of encryption we provide for that transmission. All those things were included in our telehealth consent. Next slide. So the next question we ran into was who can provide it? So for us in our state, it can be either a PTA or a physical therapist, or PT or a physical therapist assistant. So that was great. That allowed us to expand to our kind of all our clinician levels. However, supervision requirements are still in effect. So depending on the state, whether or not the PTA needs direct supervision or indirect supervision is allowed, they would still, if they're providing telehealth services, they would need to have that supervision level consistent with state law. I would say a positive benefit was in the 2021 final rule from CMS. CMS amended the final definition of direct supervision for Medicare to include not just on-site supervision, but that a PT or OT is available over synchronous audiovisual technology. So it allowed us to continue to use PTAs and CODAs and not necessarily have the PT on site, but just to be available for any questions or anything that arise. So that was a great addition that came out of a lot of the legislative work that we did over telehealth during the pandemic. What are some of the acceptable locations for telehealth? Well, most of the typical originating sites is really the location of the patient. This can be the home, a hospital, critical access hospitals, rural health clinics. The distance site is the location of that the practitioner is. Although there's no statutory restriction on the distance site, I think there is some confusion about whether you need to be in a clinic or you can be somewhere else when you're providing telehealth. And I think that comes from some of the contractual restrictions on the distance site. So although CMS waived the requirement to list multiple distant site addresses on your Medicare enrollment, this allowed providers to bill from the currently listed location. So your standard clinic location, even if you provided it at home or at a different site, that waiver allowed you to do that. Typically, you would have to list all of your brick and mortar clinic location plus any other location that you provided telehealth services. This requirement is generally accepted by a lot of the in-network payers or the commercial payers, but it's something that you definitely want to kind of check with the commercial payer if they also provided this waiver for your in-network contracts. And then we need to figure out if there are any specific documentation requirements, right? So we did find that we needed to, in our telehealth visits, we needed to include the originating site patient name and address, the distance site provider name and address, as well as kind of a statement along the lines of the service was provided in the response to the public health emergency. That allows all our documentation and our billing and coding to fall under those waivers provided by both CMS and a lot of the commercial insurers across the country. Next slide. Next slide. So the next big question is, are we going to be able to get paid for it? What are the type of things that we needed to do billing and coding wise that were unique to telehealth? So for telehealth, there's really two things that you need to do uniquely. Add to your claims after you complete a telehealth visit. You need to use the appropriate place of service code, as well as the appropriate level 1 modifiers. These codes indicate where the service was provided, as well as provide some extra detail to the standard CPT code, acknowledging this was provided via synchronous audiovisual technology. Next slide. So the most common modifiers that you're going to use are the 90, at least in PT/OT practice, or the 95 modifier. And this again indicates services were delivered whatever, and in real time, excuse me. And then the GT modifier, some insurers still require the GT modifier, even though they were replaced by the 95 modifiers in 2017. The GQ modifier is delivered for the asynchronous telehealth version, and then the CR modifier you would add to indicate the services are part of the catastrophe or disaster related. This was especially important initially when Medicare allowed PT and OT to provide e-visits. Next slide. Place of service code, which place of service code should we use? Well, what a lot of us found is it depends. It seems logical that you would use place of service code 2 for telehealth. This indicates that the service was provided via telehealth. But a lot of times we were asked or required to provide the office place of service code or the home place of service code. And really what this was, it was very confusing, and it changed regularly, and we really had to stay up to date on it. But a lot of it was the payers knew when they put the waivers in allowing for telehealth services from PT/OT, they needed to be able to pay at parity. And a lot of, at least in Washington State, they had planned on having a whole year to be able to do that. And now they had to be able to do it, kind of March and April of 2020, almost 10 months earlier than they initially planned. So the differences in coding, the differences in the modifiers you need to ask, the differences in the place of service among payers, a lot of the time was to allow their systems to recognize the claim and make sure that it was paid out at their in-network or contract rates. So next slide. And I think that's most of what we did. We found in our organization, because everything changed so quickly, was really to kind of create a matrix that looked at what CPT codes were allowed, what modifiers we needed to attach to each procedure, and then what the place of service code was for that specific payer. And this is kind of a matrix that we used and across the board, and our clinicians and our billers and coders kind of utilize this. It was updated weekly. That allowed us to get a lot of our claims through, and we really had very few denial rates. And most of our claim, I think at one point, I think I shared with Anthony in our state meeting that we had a 98% first time pass-through rate, which is really good. It's really good for normal claims. It's excellent for kind of a new medium that we are providing kind of over telehealth, and to really have a 98% pass-through on telehealth claims during a pandemic was really great and allowed our practice to stay afloat. So I think that's most of what I had. Now I'm going to turn it over to Anthony and kind of tell the clinical practice side of all this.
Thanks, Ben. And gosh, seeing that matrix just reminds me how quickly things were changing on a daily basis, and how nice it is to have everything on one screen now that's sort of permanent. Next slide, please. And like all of your practices, in a moment, everything sort of changed. We're seeing patients in person, and then we've got to figure out how to see patients amid a pandemic. And what we discovered was telehealth has a lot of value. And for a month or two, maybe 3 months, we were seeing patients exclusively via telehealth. And even though now we're seeing patients in person, we continue to use telehealth in our practice. Next, please. Initially, some physical therapists were sort of hesitant to try telehealth, and they would sort of say, well, physical therapy is hands-on. How do we do physical therapy through a video? And really, we have a lot to offer. We're great listeners. We can do an examination, an assessment. We can educate our patients, provide self-treatment techniques, show home exercise programs, look at ergonomics. And one of the key things, benefits with telehealth, as Ben demonstrated, is that we get to see the patient in their home environment, which is really beneficial. So there are limitations, but telehealth has value. Next, please. And one more. So I thought I would just start with a case, just so you can see how someone might progress through telehealth. And so I had a patient that I'd seen previously in 2017. He had a right shoulder pain. He was having shoulder pain with playing tennis. He was 60 years old, right-handed male tennis player. But he was also having shoulder pain with sleeping and ADLs and things of that nature. So he got an MRI, and it showed pretty significant glenohumeral arthritis, partial thickness rotator cuff tears, a large osteophyte, in fact, at the head-neck junction of the humerus. And this image that you see on your screen, this looks pretty similar to his. This is not his image, but the osteophyte that he had was roughly 3 times as large as the one on the screen. And he also had degenerative changes at the AC joint. So he had some tearing in the rotator cuff, arthritic changes, and we kind of communicated via email, and we talked things through a little bit. Next slide, please. So after talking with his doctor, he decided, hey, I'm going to have a PRP injection, and we're going to see if this works. And they scheduled the injection for March 10th. And that's kind of when the pandemic started. When I talked with him, I wasn't even thinking about doing telehealth. I was just treating patients as is. I maybe connected with him last week in February. And so as we got closer, it seemed certain that things were going to change. And on March 13th was our last day treating patients in the clinic, and then we sort of pivoted to telehealth. Next, please. So he sent me over, he had the injection. I told him we're figuring things out, we're going to be ready to roll. But the physician gave us some guidelines, and the physician wanted him to start physical therapy 2 weeks after the injection. Start at a low level, work on scapular thoracic mobility, gradually work active range of motion, use manual therapy as needed, and then progress to strength and parascapular strengthening at 4 to 6 weeks. Next slide, please. So 2 weeks later, we were up and rolling with telehealth, and everything's going smoothly. So we do our initial examination on March 24th. I do a visual inspection. He has some minimal swelling in the shoulder, no bruising or anything from the injection. Shoulder flexion and abduction were limited by 10 or 20%. Horizontal abduction and internal rotation were quite a bit limited. I felt that was probably due in part from the osteophyte that he has in his joint. He had mild discomfort when testing gentle shoulder isometrics and external rotation, internal rotation, and abduction. And he had done physical therapy before, and he was active, he exercises. So we agreed that we would meet once a week via telehealth. And so on that day, on the initial assessment, we started his home exercise program. Next slide, please. So a week later, he's doing a lot better. He's doing better. His shoulder flexion, abduction are almost 100%. He's still quite a bit limited with horizontal abduction and shoulder internal rotation, but he's still having problems sleeping. He's got some achiness between his scapula and his spine. He has some anterior shoulder discomfort. Normally, I would be able to get in there with my hands, do some manual treatment, do some manual assessment. We're not able to do that via telehealth. So what I did was I taught him some self trigger point reliefs. And that's kind of what some of these pictures demonstrate. And these pictures are 3 to 1s that we use with him. And we did do some modifications over the next few visits, but this is roughly what we did. And next slide, please. And really, he did quite well. I saw him for 6 visits over 9 weeks. I saw him once a week for 3 or 4 weeks, and then we tapered it to every other week. And he felt that even though we weren't able to do manual therapy, he felt that the myofascial and trigger point release that we were able to talk through on the telehealth appointment were really valuable in progressing him. He also continued with his home exercise program. And we did discuss, maybe not returning to tennis at this point in time because he didn't have full shoulder internal rotation. And all his ADLs and household chores and yard work were all pain free. So that wasn't the case beforehand. So we felt like at this point, let's not go back to tennis. Maybe we'll meet down the road and discuss that at another time. But he was really happy that he was no longer having shoulder pain and we had a successful outcome. Next, please. And next. So the key to making all this work is really setting up the patient and setting up the provider. And so I think the key thing for setting up the patient is setting them an email ahead of time, just with some expectations. So you're going to want to use a computer with high quality audio and video. You could use a tablet if you have a stand. You may be able to get away with a phone, but you've got to have pretty good vision to use that, to pull that off. You got to be able to step away from your screen so that you can move. Wear clothing that will allow for movement and visualization of the area. So if you're going to work with a shoulder, you got to wear some sort of tank top or something that will allow me to see that. They need to have a stable internet connection. And then I think another key thing is letting them know when they're going to get the invite for your telehealth appointment. And so we normally send that 5 minutes ahead of time. And that way it's right at the top of their inbox. They don't have to search for it. It's just right there. And that works pretty well for us. Next slide, please. And then the second part is setting the provider up. And this is just as important. So these are some pictures of how I kind of operate. Initially, I did use my phone on a stand. I still use my phone occasionally, but I'll use a tablet too at times. And I like using a tripod because I can really dial in the camera angle and I can get down on the floor. I can move around, and it allows me to be really flexible with showing patients different treatment techniques and exercises. We also have to have a quiet space. So you got to eliminate background noise. You got to respect patient privacy. So if you're out in the gym, like in this picture, make sure that there aren't other patients in the background or that other people can't hear what you're saying. And you've got to have some space. Next slide, please. And so when you treat someone in person, there is something called bedside manner. And with telehealth, it's webside manner. And that was a new term to me with telehealth. But basically, you offer the same courtesies as an in-person appointment. You introduce yourself, you welcome the patient, you look right at the camera, you use professional dress, you pay attention to the backdrop, your dress, you introduce other people in the room, and ask permission. So if you know that someone's going to be coming in to ask you a question or something, you might want to ask the patient if that's okay with them. And just smile and be personable and be yourself. Act as if the patient's right there in a room with you. Next slide, please. So you want to make sure that the camera angle is right. So you want to be able to look right at the camera angle so that the patient feels like you're looking at them right in the eye, as if you're in person. Lighting is important. This is a treatment room that I typically use, one of the treatment rooms. And so you've got to have fairly good lighting, do a sound check, and test your equipment ahead of time. Make sure that it's working properly. Avoid clutter and let the patient know that you're going to type or that you're going to do something on your computer. So I might say, hey, Janet, I'm going to just type in, or I'm going to add that exercise right now on your home program. So that's what I'm doing on my computer. Feel free to ask any questions while I'm doing that sort of thing. Next slide, please. An important part of gathering information for me is getting the subjective information ahead of time. We have adopted electronic intake forms since the pandemic and using telehealth, and we use a third party called IntakeQ. Many EMR platforms now have those built in, and you can just forward those to the patient as needed. You can also use a fax machine or have a HIPAA compliant email service do it for you too. But the history and the subjective part is really important because this is how you connect with your patient and build sort of that rapport with the patient. You want to listen carefully, find out details of their condition, figure out where their functional limitations are, and figure out what their goals are. What do they want to get out of this telehealth appointment? Next slide, please. With the examination, I sort of start with my visual inspection, postural assessment, and then we start to look at range of motion, and I sort of qualify that. I basically say visually estimated, and then I may look at gait or do a functional movement screen. That's really how we'll assess strength, is through, we'll draw some conclusions based on how they move from a functional perspective. And we can also do some sort of gentle shoulder or hip or knee isometrics, or we can have a caregiver help with that. But then you have to qualify the information that you're getting. And basically, you're not getting the same information as if you would be doing the manual muscle test yourself, and you want to qualify that with your documentation. We'll look at ADLs and how they do their household chores, their home setup. And again, this is a big advantage with telehealth, like Ben suggested earlier. We may incorporate some special tests, look at their workstation setup, and other nuances that may be important. Next slide, please. For me, an initial assessment takes about 45 to 55 minutes. And follow-up appointments, when you're meeting with the patient, is usually a little bit less. But there is a little bit more work after the fact. So a lot of times I'll spend a few minutes emailing with the patient or sending them a new home exercise program, things of that nature. So you just want to keep that in mind. Next, please. A key part for me is having an asynchronous home exercise platform. I use MedBridge, but there are a lot of them out there, and I don't know if anyone's better than the other. But one of the really useful tools with this is a lot of them will allow you to sort of interact with the patient through that exercise program, and the patient can give you feedback on how things go with a particular exercise, and that can be really beneficial. So next slide, please. Now, all that said, there are limitations to telehealth. It may be more difficult to connect with your patient. You're not meeting with them in person, and some people are more natural on the computer than others. Another thing is that the details of an in-person assessment may not be fully appreciated. It's difficult to do a detailed biomechanical assessment. You can't really do passive mobility testing. More difficult to do neural mobility testing. A balance assessment can be difficult, may not even be safe. You're not personally palpating the patient. You can have the person sort of palpate around and see how things feel, but you're not actually doing that. Manual muscle testing is different. We can't provide real hands-on treatment. You can teach people how to do it to themselves, and that can be valuable, but there are limitations with that. And like I said, it may not be safe to do a balance assessment, even with a caregiver there. So all that said, at the end of your telehealth appointment, you may need an in-person appointment. And so that could be one of your conclusions at the end of the appointment, and something to keep in mind. Next, please. I'd like to document a few things with the telehealth appointment. I like to add or just mention why I'm using telehealth versus an in-person appointment. So during the pandemic, that was easy. We're meeting via telehealth due to the COVID-19 pandemic. I also like to put in there why telehealth was helpful and necessary in the recovery for the patient, just to give sort of some supporting documentation why what we're doing. But also I list limitations of my examination, the assessment, and treatment. This is valuable, but there were limitations in it. And then I'll qualify my objective findings. For example, range of motion, I'll say it was visually estimated. I have had a couple patients where I estimated range of motion, then I saw them in person, And it wasn't quite the same as what I thought I was seeing on the telehealth appointment. You know, if a caregiver assists with a technique or a special test, I'll put that in there too. If I walked a person through a special test, I may say that, you know, the response suggests a certain diagnosis, but maybe not conclusive. So yeah, next slide, please. A couple other sort of points. It's not uncommon to get screen fatigue. I remember a few days where I had maybe 8 patients in a row telehealth, and at the end of 8 patients with a screen, it's a long day, and you need to give yourself some breaks in there so that you don't get screen fatigue is what I call it. I don't know if that's an official term or not. The other thing to think about is when you have an in-person appointment, a patient will leave work, they'll drive 15 minutes to your office, they'll sign in, they may sit in a waiting room for a minute or two, and then they come in and you treat them. So they kind of mentally prepare for that appointment. But what I found is some of these appointments with telehealth, a patient will go directly from a work meeting, and then 30 seconds later, they're in a telehealth meeting with you, and they haven't really mentally prepared for that appointment. And so you just want to kind of keep that in mind, and you may need to let the patient know, hey, you need to take a little bit, you need to like defrazzle before you come into your PT appointment. And the other thing that I hear sometimes is that some providers feel like they have better compliance if they had a relationship with the patient before their telehealth visit. So say you saw a person 6 months ago for something, and then now that you're seeing them via telehealth, there's better compliance there when you have the relationship versus if you just met them initially via telehealth. So yeah, and I think that's all I've got here. The next slide. Yeah. So thanks so much for having me, and I'll turn it over. Great.
Sorry, it took me a moment to start my video. Thanks, Anthony and Benjamin. My name is Kaitlyn Andreason again, and yeah, I'm happy to be a part of this NTRC Telehealth Hack series. I'm a speech language pathologist that's working in the pediatric population, so I actually don't know how many are here that work with pediatrics, but I will address some of the pediatric side of telehealth. No, go ahead and go to the next slide. So I wanted my outline to kind of follow the objectives for this webinar. I won't spend as much time in some of these areas as I was planning to because Benjamin and Anthony addressed some of these things already, but this is the outline. So you can go to the next slide and then the next slide again. Okay, so I have been using the term telepractice mainly because the American Speech Language Hearing Association recommends telepractice rather than telehealth. However, they've used the word telepractice historically because they don't want it to sound like telehealth is only provided in a healthcare setting. Since there are a lot of speech language pathologists that treat patients in the school setting, they use that term telepractice. And so telepractice has actually more historically been used in school districts, especially when they're serving rural areas. So speech language pathologists have actually had access to telehealth for quite some time in that setting. But of course, the pandemic allowed for a more widespread use of telepractice, including in rehab services, which is the setting I'm currently in. So COVID-19 also for me established the need to research and implement best practices in telepractice. You can go to the next slide. So again, won't spend much time on this. Benjamin already addressed this. There are different types of telepractice. When we think telehealth in general, synchronous is usually the type that we're thinking of. That's the real-time audio and visual connection. I definitely use a lot of synchronous type of telepractice in my practice. And then I also feel very strongly about the hybrid approach where you can do in person as well as some sessions over telehealth. I've seen that actually works well for a lot of patients. So you can go to the next slide. I also wanted to include some of the evidence for telepractice based on population served. Again, I think it's important to find best practices, and if there is any evidence-based practice for telehealth, I'd like to use that in my practice. And so this is just a list of research articles where they've used and implemented telehealth in their practice, and then kind of the outcomes from those research studies. Within the pediatric population, there probably have been more studies conducted for the discipline of speech language pathology than there have been in occupational therapy and physical therapy. But the research still is limited. That's something that is written all on the ASHA practice portal for telepractice. There needs to be more research completed because technology and telehealth has kind of outpaced research opportunities for these things. And so, but based on my research, I wanted to just share some of the articles that I came across. So here's a list of some, and then if you go to the next slide, there's some more based on population served. One thing that I thought was interesting, at least in my clinic, feeding, when you're working with feeding disorders, it's actually helpful to be able to see the child in their home environment. Again, you want to make sure that it's safe to conduct a feeding therapy session over telehealth, but that's been one of the pros of having telehealth as an option, is because you can actually see the home setup. Okay, you can go ahead to the next slide. And then next slide again. So I won't spend a ton of time on reimbursement. I know Benjamin kind of went over this a little bit. Something that I did want to mention for something that's important when it comes to reimbursement is licensure. So go ahead and you can go to the next slide and we'll talk a little bit about licensure. So the client's location determines the site of the service, and then telepractitioners actually need to be licensed for, well, for speech language pathology. I just know for my discipline, we need to be licensed in both the state in which we reside and then also the state in which the client is located. So I know one of the benefits of telehealth is to be able to provide services to someone that lives far away from your clinic. But that's something to keep in mind. If they are actually out of state, then you need to have a license in the state that they are receiving services, as well as in the state in which you're providing services. There are healthcare organizations that are trying to create licensure compacts, and I know ASHA is currently supporting an initiative for this. And so hopefully in the future, there can be a compact which will allow more telehealth services to be provided. But as of right now, you do need to be licensed in both states. You can go to the next slide. And then reimbursement. As of right now, coverage and payment of telepractice services, at least again in my clinic in the state of Utah, for the most part, they are being reimbursed and covered through the pandemic. We don't know if this is going to be something permanent after the pandemic. And so again, we haven't had very many issues as far as insurance companies being able to reimburse patients, but it will be something that we have to address more in the future. So still, it's recommended that clinicians verify telehealth coverage prior to initiating services with the patient. Okay, you can go to the next slide. And then the next slide again. So I just wanted to go over a few considerations for successful integration of virtual services. Anthony provided a lot of really great information on this when it comes to the physical therapy discipline. So in regards to the pediatric population, I just wanted to talk about these things. So the first is clinician qualities. When you're completing a telehealth visit with a pediatric patient, it's so important that you are animated and engaged with the patient over that visual link, because again, if you're not animated, you're really not going to keep the child's interest. And so that's something that I think is really important, is the clinician needs to be aware of some of the things that they need to do to keep the child engaged in the session. You also have to be really flexible and have multiple activities ready for your session, because if a child's not interested in one activity, you've immediately got to try something new, because you don't want to lose the child's interest. And we of course have parents that are there with the child that are kind of acting as the moderator, helping them stay engaged. But of course, you do want to do all you can to keep that child engaged in the session. So clinician qualities is an important consideration. Also, the patient and client selection. Not all patients are going to be a good fit for telehealth. I've actually been surprised by some that did end up being great fits for telehealth, but again, not everyone's going to be a good fit. So it might take some trial and error to determine if the patient is a good fit for telehealth services. And of course, it's important to think of if this is the only access the patient has to services, then it still might be beneficial for them to receive telehealth services, even if they're not the perfect candidate. And then another consideration is the technology available to both the clinician and the patient, and then also the technology available to the clinic. Anthony and Benjamin both talked about that. It's very important to have a good internet connection. We have had internet issues at times, and it really affects our telehealth visits, of course. And so you got to think about what technology is available to yourself and to the client. And then also the therapy approach. When you're working with kids, I work with a lot of toddlers, and so sometimes, of course, I won't be able to provide direct treatment services over a telehealth visit because they can't really engage through that medium. But we do a lot of parent coaching, and so you can observe what the parent is doing with the patient and then provide strategies and recommendations based on that. And then, of course, when the child is older, or if they if they are able to interact well via a telehealth platform, then they're still a good candidate for telehealth services. And then again, a hybrid approach is something that I think is beneficial because you have established a connection with that patient, and then when you see them on the screen for telehealth, they're excited to see you, and it's kind of a continuation of that in-person care. Okay, you can go to the next slide. So I'll go over a couple of quick case studies. I know we're running low on time, so I'll go through this quickly. So I've changed the names here, but Caleb was one of my patients, a 3-year-old, and he had a diagnosis of an expressive language disorder and a phonological disorder. The approach that I used to treat this patient was direct treatment and parent coaching. I completed his evaluation prior to our clinic shutting down when the pandemic hit. When it opened again, the parents still preferred to have a telehealth option. They weren't comfortable coming in for in-person services. And so even though Caleb was young, I was a little concerned about his age, but he was actually very motivated by on-screen games and activities. I have some favorite websites that I use with kids all the time. One is Ultimate SLP, Boom Learning is another one. And so I have a lot of games that I use with kids that I share my screen, and I wish that we had an interactive capability with our platform, but we don't. So I'll often have the child tell me, of course, what they want me to do on the screen. And so anyway, some children are more engaged than others, but Caleb was very engaged, and within 10 sessions, he met 4 out of 5 of his goals. The parent satisfaction was very high. They reported great progress from week to week, and they were really happy to have the opportunity to stay at home. And then also telehealth was effective because it made transportation and childcare issues easier on the family. Normally they would try to bring some siblings into the appointment with the child that I would see in person. But when the pandemic hit, our visitor policy changed to where it was just the child and the parent. And so that affected childcare. And so this family was very grateful for the ability to have a telehealth option. So you can go to the next slide. Cruz was a 7-year, 4-month-old male, expressive language disorder and articulation disorder. Again, I used direct treatment and parent coaching with this patient. He was a kiddo that was pretty distractible. You could lose his interest pretty easily, but he did respond well to redirection from both the clinician and his parent. His mother was very highly motivated, and she followed through with all of the home program stuff that I had sent to the family. And so within 8 sessions, Cruz had met all 6 of his goals. And again, all of those sessions were over telehealth. Mom reported a lot of satisfaction. They live 45 minutes from our clinic, and so she was really happy not to have to travel each way, and she actually hopes that this becomes a permanent change for us, that we can continue to have telehealth visits. And then next slide. Last one was Tommy. He was a 2-year, 4-month-old male. He had an expressive language disorder. He was saying I think like just a few words when I first met him. We did a parent coaching model. So again, this is a younger kiddo that couldn't really interact very well over telehealth, but I talked to parents and I demonstrated things over the screen, and they would then demonstrate the same strategies back to me. And Tommy made a significant progress in only a couple of sessions. He was using over 50 new words and combining words into 2-word phrases just after a couple of sessions. So he had met 3 out of 4 of his goals, and parent satisfaction was very high. They felt like he didn't need speech therapy after we had had a couple of sessions. So that was another example of a really successful telehealth session and treatment opportunity. Okay, I think that's it. I just have references after this. I'll give it back to Nicki.
Thanks, Kaitlyn. And actually, why don't you stay on, because I think Ben and Anthony have been really busy answering questions. So there's just a couple in the chat box for you.
Okay.
The first one is, how do you establish safely to decide if telepractice is appropriate for home feeding?
Oh, so yeah, that's actually a great question. Depending on the child's diagnosis, of course, so if they have significant swallowing issues, and the parent, if you haven't established a relationship with the parent and know the safety precautions to take when it comes to the swallowing difficulties, I would probably not recommend telehealth services, but a lot of our patients are what we call, picky eaters. You can definitely work with those types of patients over telehealth and again, it's really helpful to see that home environment at that point, because you can talk about setups at home that might be more effective. When you're seeing them in the clinic, of course, you have the setup that the clinic has, and you don't know exactly how to help the parent at home. So that was kind of the pro of having the ability to see their home environment. But that's a great question. Of course, you want them to be safe at home as well.
Great. And then we have another question in here that I'll probably share with you privately, and then you can answer it and get it back to us, because we are running out of time. So
Okay.
I'm going to hand it back over to May for closing comments. I just want to say thank you to all 3 of you. You did an excellent job and really great information. So thank you.
Thank you, Nicki, and thank you again to our speakers, and also Nicki too for your great facilitation. Just very quickly, our upcoming session is for March 24th. The topic will be on behavioral health services and early intervention. Registration information will be up soon on the TRC website. Next slide, please. And know that you will be getting an evaluation from us. It really helps us out if you filled out that evaluation form. And additionally, if you are interested in CE credits, know you have a hard and fast deadline of March 26th to get that completed. Otherwise, you will not be able to access the CE credits. A recording of this webinar and the PowerPoints will be made available on the TRC website, the Consortium website, telehealthresourcecenter.org in about 48 hours. Once again, thank you to our speakers, Anthony, Kaitlyn, and Benjamin. And thank you to our moderator today, Nicki. Hope everybody has a great day and stay safe.